When people think about cosmetic surgery, perhaps the number one surgery that they think about in general is a nose job, commonly referred to as a nose job, but in our industry, it's referred to as a rhinoplasty. Today, we're going to explore the topic of rhinoplasty, and today I'm very fortunate to have with me Dr. Daria Hamrah. Dr. Hamrah is a board-certified oral and maxillofacial surgeon and a facial cosmetic specialist. He is practicing in the Washington, D.C., Virginia area. He's been practicing for well over 15 years. He's not only trained in cosmetic surgery, but in facial reconstruction. Has done an enormous amount in the field of facial reconstruction in his training and in his charity work. But today, I'm going to pin him down and talk about rhinoplasty. Dr. Hamrah, thank you so much for being with me.
Thank you, Peter. Thanks. Honored to be on your podcast and super excited about our conversation.
Me too. I think it's going to be a really good topic because so many people are interested in rhinoplasty. And the thing is, not everybody understands what's involved with it. It's not simply taking a hump off of the top of someone's nose. It's a pretty engaging operation. But before I kind of go in there, I want to talk about you a little bit. Your path to getting out here and practicing cosmetic surgery in the United States was not a simple one. You grew up in Germany, correct?
That's correct.
And tell me how you ended up coming out to the United States.
Yeah, so I was my parents, they immigrated to Germany from Iran, and my mom's family is from Azerbaijan, and so I was kind of used to this. I was born into an immigrant family and into a country that I grew up and later found out to be a little, let's just say, not welcoming to foreign people from other countries, just because Germany is a very traditional country. Now it's totally changed. I'm talking about 40 years ago where I grew up. And so it never felt really home to me. So I didn't really insist on staying there. I remember first time I was 16 years old, I came and visited some of my relatives in Northern California. I fell in love with the States. I mean, I was 16 and I saw the land of opportunity, and I went back. I told my parents, you know what, I'm going to the States when I graduated. And my parents told me, well, you might take advantage of free education here, get your degree here, and then go over there, which is what I did, not knowing that it's going to be extremely hard establishing myself here as a foreign graduate. So I had to go through a lot of hoops and obstacles to get to where I am. But I always tell to people that are looking up to me and asking me how many years I've been spending or I went to school for and how hard it was. I said, look, you're passionate about something, you have a mission. It's not about the years, it's about the journey. So I would do it over again, and I just enjoyed the journey, and that's why I'm so passionate about what I'm doing. It wasn't handed to me. I went and grabbed it, and now I'm just running with it and trying to inspire others that are interested in this field.
Well, I think you've done a magnificent job, and we're very happy to have you here today. So today, while you do so many other things than just rhinoplasty, and we'll talk about that going on, I wanted to talk to our audience today about really what is a rhinoplasty. And can you give us kind of an overview when somebody comes to your office and they say, oh, doctor, I want my nose done. What is it they're coming for? Is it, is it everybody coming for the same thing?
That's a great question. First of all, to classify it, now we have non-surgical rhinoplasty, which is a fairly new thing, which really means using fillers to make some minor contour corrections of the nose. Unfortunately, patients expect way too much from it, and people that are non-surgeons are overselling it. So that creates a lot of confusion. But for the sake of conversation, let's just talk about surgical rhinoplasty, which is what a real rhinoplasty is. And rhino means nose, and plasty means changing the shape. So it basically means reshaping the nose. Whether you have to add to it or subtract from it, whatever it takes to get to a desired shape. And many patients already intuitively have a great understanding as to how they would like their nose to look like and how it would fit their face. Interestingly, which in the beginning of my career, I thought the opposite. And what I was taught is that, we're supposed to tell them how their nose is supposed to look like because we know best based on all these facial analysis that, all these studies that tell us about the facial thirds, facial fifths, and, the distances between the medial canthi to the alar width. And I know I don't want to get too technical, but so many measurements. And what we forgot is to actually listen to the patients. And how many times have you seen patients come to your office where they've already contoured their nose with makeup and created these highlights and shadows and light reflections? And it goes to back in Dean Toriumi in, I think it was 06 or 07, one of the masters in rhinoplasty presented this landmark article where he showed that our perception of anatomy of the nose, of the anatomy of the nose and the aesthetics, is all about light reflections and shadows, and that's how we perceive things. And when we make changes to the nose, we work with shadows and light reflections. So there's so much artistry in it. It's not just a mathematical equation or putting a diagram on a face. So there's so much visual artistry and then, of course, execution that goes into it, together with really, I spent at least an hour with my patients to discuss the nose that not only fits best to their face, but that they want. So a lot of my work goes into rhinoplasty before I even enter the operating room in a conversation with my patients.
I think you brought up some really good points. Those of us who have gone through the training of rhinoplasty really do it in a very mathematical and anatomical way. But of all of the procedures, surgical procedures that we do in aesthetic surgery, rhinoplasty is truly a mixture of art and science. And if you can't look at a patient's face and make adaptations based on the structure of their face, their ethnic background, their wishes, their desires, you're going to create an unhappy patient. And the nose is difficult. I mean, the nose is a complex structure. I explain to my patients, it's like a sandwich. You have an inner lining, the mucosa. You have the outer lining, the skin. And sandwiched in between those two areas are the bony structure on the top of the nose and the cartilaginous structure on the lower portion of the nose. And all of those structures play a role not only in what you're going to be changing, but those can change after your surgical intervention. And so you have to really take into account not just what you see from the patient right away, but anticipate what gravity is going to do and what tension is going to do. When you have patients coming to you, I have to imagine that sometimes patients will bring in photographs of either magazine articles or celebrities and say, I want my nose to look like this. How do you use that, and how do you caution against that?
Yeah, you forgot to mention a complete photo collage, like a 4 foot by 5 foot photo collage. It happened the day of surgery. A patient of mine came with it the morning of. She said, by the way, I want you to go over this with you. But to answer your question, I used to view these things more judgmentally, just because that's, I guess the traditional way we address plastic or cosmetic surgery was that this notion that we don't want to set false expectations. So we don't want to give images too much emphasis or attention, just because once patients get fixated on a particular image and anything else you achieve, it's a failure. Well, it didn't occur to me that this is not entirely true until my first dilemma with a patient was such that when I did the reveal and I did exactly what we had discussed, and she started crying. She was extremely upset about the result, and I asked her why she's upset. She's like, well, it still looks too big. And I said, well, there's a lot of swelling, et cetera, et cetera. And she said, no, the tip looks too wide. And preoperatively, like I always had been doing, discussing what the patient desires, she had told me, I just want you to remove the hump. So long story short, when I told her if I remove the hump, the tip is going to look different, because with rhinoplasty, the challenge is you make one change on one end, relative to that change, something else will look different. For example, if you have a large nose, you have a large tip, and you have a large hump. Now, when you remove the hump, now the tip that you haven't touched appears larger than it had before, because relatively to the rest of the nose, now it's larger. So when I tried to explain it to the patient, this patient was extremely insisting that, no, I do not want you to touch the tip. And so then obviously she was disappointed. And so I learned my first lesson like that. And I decided, you know what, I need to be, not only I need to be more clear about the final outcome, but the patient needs to understand, has to have some sort of visual. So I started the morphing of the nose, and it's so hard. One of the things, Peter, it's the toughest thing in rhinoplasty. When you have just a conversation without pictures, you will rely on the patient's verbal communication skills and level of understanding and awareness. And then as the other variable is your interpretation of what the patient says. So there's so many unknown variables that after having performed rhinoplasties all these years, I realized we need to use photography. We need to use pictures and even examples of other patients or other people that the patients love their noses, at least as an example, to be able to have a scaffold for what we're going to do. And that has tremendously increased my success rate. And I measure success by my patient's happiness, not by what my peers or myself think it looks good, but what the patient says. If the patient is happy, that's a success, period. Of course, you have to be able to breathe through the nose as well. That's another factor which we're getting into. So now I use photography. I tell my patients, bring as many pictures of noses that you love and noses that you hate. And then I use that like a computer in my brain. I use it as data to come up with a nose. So I design a nose that I think, based on the information that they give me, that they're going to like. 9.5 out of 10 times after my first morphing, they're like, oh my God, that's exactly what I want. And sometimes I have picky patients, which is fair enough. They have a higher perception and they're more artistic, and they're more picky, and they go like, well, I want the slope a little bit more or slope a little bit less. And I just modify it, and then we're done. When it comes showtime, when I'm in the operating room, that's pure execution. Now I have to let my toolbox and my skills speak, and that's, I think, so at those 2 points is where success and failure happens. Number one, communication, and number two, execution. Communication is a learning progress, such as execution. That's just practice, practice, practice. I'm not the same surgeon I was 5 years ago. I'm not the same surgeon even I was last year. I'm not the same surgeon I was beginning of this year, heck. So we learn through our own trial and errors and mistakes and failures and successes every single day, and that's kind of like a journey that I've been through.
Yeah, I think you hit on some very good points. There was a time in my career where I thought the morphing technology, the simulation, was just total bullshit. It was a total marketing hype and a waste of time. And I realized, as you very adeptly pointed out, that really patients are much better communicating on a visual than on a strictly verbal level, because my interpretation of what a slightly turned up nose is different than the patient's. If I'm doing a breast surgery, my concept of what 450 cc's looks like is different than somebody else's, or what a B cup looks like is different. So having that technology has changed over the years, and it's become better. And I think that all of us have to really realize that technology is going to be part of what we do. And as long as we're not just totally bluffing our way through this and saying this is what we can absolutely achieve, it's a good tool. Now I almost always, when I want to do a case, show the patient through this computer simulation. Look, this is what I think I can achieve. Is this what you want? And of course, I tell them like, the computer's not doing the surgery, but at least we are kind of on the same wavelength of what our expectation and goals are. And then, as you mentioned, it's practice, it's experience, it's knowledge of anatomy. And with any surgery, there's also, you got to hope that everything goes the way you want. And you have to explain to everybody that, especially in rhinoplasty, things don't always end up a month, a year down the line as they did at the end of the operation. So I think it's a very good point that you brought up, trying to be visual.
To that point, Peter, I think I just don't want this to get lost because you made a very good point that, at the end of the day, I tell my patients, like, I'm a human. I'm not perfect. I'm not like a computer, like, can design something and then spit out exactly what was designed. So there's so many variables that have to do with healing and individual. There's so many variables that it's beyond this podcast to get into. So there is an unpredictable factor. And I put it at about 15 to 20%. I tell the patients, look, 80% you're happy. If you're happy with 80% of the perfect result, I'll operate on you. If you don't accept the 20% that you might not be happy with, I'm not operating on you because I don't want to I don't want to make you unhappier than you already are. So, so that's how I choose whether or not I operate on someone. And the other aspect is also as far as technology, we used to have these expensive softwares and such. I actually do it on a simple app on the iPad, and it takes me literally maybe 15, 20 seconds to do the morphing right there chairside on the patient. Patients actually love it because they can see the transformation and they understand what I'm doing during the surgery. And I think a lot of the communication has also to do with trust. And part of it has also to do with patients trusting us when we can show them what's going to happen in addition to the communication. And I found that to be a much more valuable tool than just conversing with patients. Just like you in the beginning, when I trained 15, 20 years ago now, the mindset was so different than it is today. And I think communication is really key when it comes to setting expectations.
Yeah. And with the nose, we have, as we talked about, the underlying structure is comprised of bone and cartilage, which hold up the skin. And when those elements are not harmonious in size and shape, a nose may appear too narrow or too wide or flat or bulbous or even bumpy on the top. So all of those individual variables have to be taken into consideration. There is not a single procedure that will handle everybody. And as you mentioned earlier when you talked about breathing, that with rhinoplasty, as opposed to just about every other cosmetic procedure, you are really having a dual procedure. You're talking about aesthetics and function. And function in this particular operation is probably more important than the aesthetics, which is very rare in any other cosmetic elective procedure that we do. Tell us a little bit about some of the functional aspects that we have to deal with when we're dealing with a rhinoplasty.
A great topic. So like we say in surgery, form always follows function, meaning for something to look good, it has to work well, and vice versa. So especially this is especially true when it comes to the nose. I overheard very early in my career, I was a fellow or resident. One of my attendings said, a pretty nose always breathes well. And I honestly disagree with it because, it's pretty only until the patients get annoyed about not being able to breathe. And I do so many revisions now where patient had their rhinoplasties really up to 20 years ago. And for 20 years, they haven't been able to really breathe. And finally, they got sick of it and they want me to fix it. And so for me, rhinoplasty, I never do a rhinoplasty just cosmetically without addressing the function. To me, it's a crime. You're there. It's easy to fix the functionality of the nose. You just have to know your anatomy. The maneuvers aren't that hard. You just have to spend time to learn them. And so for us not to fix the functionality of the nose, it's to me it's a crime. Now sometimes you do a rhinoplasty and then for some reason later on patients get breathing difficulties, but happens rarely, but if that happens, you need to know how to address it. Ultimately, the primary function of the nose is to breathe. And so with one thing that you mentioned about noses come in different shapes and forms, I'm here in the Washington, D.C. area. I see a lot of what we call in our medical jargon, we call it ethnic rhinoplasty. And so one point about what ethnic rhinoplasty really means, I just thought about it not too long ago. I said, why do we even call it ethnic rhinoplasty? Every rhinoplasty is ethnic. Even a Caucasian rhinoplasty is ethnic. That's the very definition of ethnicity. But, I guess back in the days, the old dogs, I guess, used the Caucasians as a reference. And I think we need to make a call to change that term, just call it rhinoplasty. I would get rid of the word ethnic. I'm not part of a particular movement or anything. This is not that. This is just purely academic and just logical thinking. It's like, why do we even call it ethnic? So everything is ethnic. So that's my point to what we call in the medical jargon, which in textbook it's written as ethnic rhinoplasty. So when we talk about ethnic rhinoplasty, we talk about Asian noses, African American noses, Middle Eastern noses, and then we have Roman noses, we have Greek noses. I mean, there's so many classifications. Hispanic noses now. So what that differentiation really was meant to do is to characterize and summarize characteristics that are specific to certain ethnicities so that our awareness is heightened and that we understand that we can't just do our cookie-cut maneuvers, which usually apply to Caucasian noses, which is essentially like 3 or maximum 4 maneuvers and then you're done. Even though that's not true, if you want to do it correctly, at least in the way rhinoplasty should be done in 2022. That may have been true in the 90s or maybe early 2000s, where we just did a little tip-plasty, a hump reduction, and a little cephalic trim, and then you called it a day. And the rhinoplasty used to take an hour. Now the functionality plays a huge role in a lot of other grafting maneuvers that we do, and now even with preservation rhinoplasty, which is a whole different topic. So there's so many nuances. My point of saying all of this is there's so many nuances. You can't do a rhinoplasty or do a proper job addressing all rhinoplasties within all ethnicities with having 3 or 4 tools in your toolbox. I just lectured the residents last Friday, and I have that conversation with my fellow. Every time we operate, I said, look, my job is to make sure that when you graduate, you have all the tools, all the rhinoplasty tools in your toolbox so that you can safely perform a rhinoplasty and where you can avoid complications, where you can get it right the first time. You do your revisions in your first surgery. And the more tools you have in your toolbox, the better understanding you have about the nuances of different ethnicities and noses and anatomical variabilities that come with different ethnicities, the better you can predict your outcome and the better you can deliver what your patient wants. And so, that's been honestly, I would say it wasn't until 7-8 years into my practice doing noses where I came to that realization that I realized I can't just do it with 5 or 6 tools. I need to know all of them. So it's, I did cadaver courses. I went to continuing education just for rhinoplasty. I mean, you need to really immerse yourself in it to become confident enough to be able to deliver.
It's a very complex field, and I think that the term ethnic rhinoplasty, as you mentioned, is a term that's used to refer to non-Anglo-Caucasian
Correct.
Patients, with the goal of improving appearance and function while still preserving distinct features of the patient's heritage. Although there are some rhinoplasties in what they consider an ethnic rhinoplasty where they don't want to preserve the ethnicity, which sometimes looks okay and sometimes looks very odd. But it's interesting when you think about that. Well, maybe in the United States, about 74% of rhinoplasties are in a Caucasian community. And we focus on what's considered like an American nose. It doesn't take into account the rich diversity of facial shapes and characteristics in today's society. And as you mentioned, when we'll use it for the sake of this podcast, the term ethnic rhinoplasty, there are so many different ethnicities that want to change certain features, but not necessarily the heritage themselves. We talked about the African American rhinoplasty. We talk about a Mexican American rhinoplasty, and Italian nose, a Greek nose, the Middle Eastern nose, and even within the Middle Eastern community, there's variations of the types of heritage that they have, and there's certain commonalities that people want to see improved. If there's a large convexity or hump to the nose, most people want to see that changed if they choose to have a rhinoplasty. But you have to maintain the ethnicity of that. Let's talk a little bit about rhinoplasty itself. In the common Caucasian rhinoplasty, oftentimes it's a reduction rhinoplasty. There may be some preservation rhinoplasty, but I think reduction rhinoplasty, and that's what most people think of. We're going to shave a hump. We're going to kind of, make the nose a little bit pointier, and that's the rhinoplasty. But that's not all that's involved in rhinoplasty, correct?
Correct. Yeah. So another aspect to the ethnic rhinoplasty, we see a lot of mixed ethnicities nowadays, right? So that's something that is not in our literature necessarily discussed. And when you look at mixed ethnicities, and I became really aware of it practicing in the Washington, D.C. area where we have a lot of mixed ethnicities. So especially with Hispanics, right? We have a huge Hispanic population. With the Hispanic population, especially Central South American, you have so many mixed ethnicities. You have the Native American, then you have Asian, then you have Caucasian, that come from Europe, and then you have from Southern Europe, like Andalusia, Southern Spain, which they came from the Middle East. They got mixed. So with Hispanic noses, you're dealing with multiple ethnicities, and then you could have, for example, someone that has facial features, more Caucasian facial features, but then the nose ethnic-wise is more Asian or is more African or is more Middle Eastern. And that's when, it gets really interesting, where for me as designer, so to speak, I have to recognize that. I have to see which one is the predominant ethnic variance in that patient's face, and then design a nose that matches that the best. And patients have trouble explaining what they want in those particular cases. So that, to me, has been an evolution in how I see the patients and how I understand what might fit best in their faces, and purely artistically, not going by any numbers or any diagrams or anything. It's just purely like you're putting oil on canvas or you're sculpting something. And so for me is understanding of ethnicities, that they're also, most of the time when we see ethnicities, they're so mixed that you have to take into account what you said. It's not just making a tip pointy, it's not just removing the hump, it's looking at the whole face, facial features that can, even in Caucasians, there could be different ethnicities. We can have Native American, or we could have, their great grandmother was maybe African American, and then you see certain facial features, and maybe high set cheekbones or larger chin, and you have to adapt the nose to that. Otherwise, everything will be imbalanced. So when we look, or the layman looks at someone's nose and says, "Oh my God, that nose looks amazing," what they really mean is that nose looks amazing, proportionate to the other facial features. They just don't know that that's what's happening, and they don't express it that way. And so that's in a nutshell how I would put it.
I think the best nose job is when you look at somebody and just they have a good looking nose and you don't think they had a nose job. But with different ethnicities, and again, there's a certain amount of generalization we have to do when we're talking about putting whole categories together. But in the in the African American population, in the Hispanic population, the skin tends to be thicker. And so, dealing with a thicker skin, you've got to figure out how much support you need to change that. When you're dealing with the tip, the African American tip tends to be not as projecting as, let's say, an Eastern European tip. The same thing with the Hispanic nose. With the Middle Eastern nose, you tend to have sometimes you can have a thick skin, sometimes you can have a bulbous tip, sometimes you can have kind of a wide bridge to the nose. You have lots of different variations. So when we talk about these types of different noses, we have to have, as you mentioned, different tools. Not everybody is a reduction. So tell us when you. It may seem almost like a paradox to people that when you're doing a rhinoplasty, you're not really doing a reduction on the nose all the time. Sometimes you're adding to the nose. You're making an augmentation.
Yeah, sometimes you're doing both. You're subtracting in one area and adding to the other area. So that's how you achieve balance. But you're absolutely right. So most of the time, even with reductive rhinoplasty, how we traditionally view it and define it, you always, at least I always add, so even though it's in small amounts, especially to the tip, and like you mentioned, the stability of the nose, you have a thick-skinned nose, your substructure, which is the cartilage, and 70% of the nose is cartilage, really. Most of the magic happens within the cartilage, to be honest. That has to be strong enough not only to reveal the changes that we make in the substructure, which is the cartilage underneath the skin, but also the ability to maintain that long term, because as we get older, our cartilages, they thin out, they become weaker, and so you have heavy skin on top. That nose can collapse, shortly after, several years after the surgery. So, that's why your toolbox is important, understanding these things, and then first, of course, you have to recognize these things. Everything what we do starts with diagnosis. You can be the best technician, but you diagnose poorly, you apply the wrong treatment or prescription for that matter. So, understanding the tissue, which is different in every patient, is key in choosing the right tools that get you to your final design. And adding, for example, like a strut, which is imagine like a tent pole that keeps the tent up. That's how I look at the strut. Keeps the tip. You can angle the tip. You can project the tip. That is really key. And then on top of it, you might add some cartilage to change the shape of the tip, or add some tip projection, or change the angulation or the shape of how the tip is going to look. All of those things we have to add to, and it's literally playing Lego. And that's why, to be honest with you, Peter, rhinoplasty is by far, to me, the most exciting surgery that I perform, because every surgery is different, and every surgery is like a journey. And no matter how many rhinoplasties I've done and I will be doing, and no matter how clear I am about what I'm going to do right before surgery, there is always every rhinoplasty is different and ends up being different. And that's what's exciting, and that's what makes it fun, to be honest. It's just, and to some people that's scary, but I find it really exciting.
Let's take our listeners through rhinoplasty. And one thing that everybody needs to know is that there are different pathways to getting good results. And you'll find, depending on your training and your comfort level, some people will do rhinoplasties different ways. And it doesn't mean there's a right or a wrong. But I just want to kind of get your take on your approach. So let's just start with basics. Do you tend to do your rhinoplasties under general anesthesia or local anesthesia?
Usually mine are under intravenous sedation. So basically, if you call propofol general anesthesia, is general anesthesia. So usually we do intravenous anesthesia, not inhalational anesthesia. recovery is much faster. Post-op nausea, vomiting is almost non-existent, and patients are in and out more quickly. And there's, as far as the anesthesia, there is almost no recovery associated with it other than that same day. So intravenous anesthesia is what I do mainly.
Do you tend to do an open exposure or intranasal exposure?
I do.
Just for our audience, the piece of nose between the round nostrils, the one in the center, it's called your columella, and those who choose to do an open rhinoplasty will make an incision at the very base of that, and then go inside the lining of the rims of the nose to gain exposure. Those who do what's called a closed rhinoplasty avoid that external excision. So tell me your feeling on what you do and why.
So I don't belong to any tribe, and I do both based on my personal comfort zone, where I know I can predict the outcome that I'm planning. So sometimes it's closed. I just want to do a little tip-plasty, maybe a minimal hump reduction. I can do it closed, and I do it closed. And ultimately, the decision to open the nose or not has to do with how predictable for me the outcome is going to be based on the maneuvers and the tools that I'm going to use. So sometimes I have to open it. Probably, I would say the ratio open to closed in my practice is about 85 to 15, 85 open, 15 closed. I do a lot of revisions, so a lot of those, they are open. It's like you have to open up the hood and then literally put Humpty Dumpty back together. So you have to open it because there's so much dissection and grafting taking place that you just can't do it predictably closed. So it really depends on what comes through my door. But the quick answer is both, and the short answer my preferred technique to answer your question that way is open.
So in some ethnic rhinoplasties, we talked about you're going to have to do an augmentation, an additive procedure, add a greater appearance of a bone structure or the cartilaginous structure. Options for that include harvesting the patient's own bone, usually rib, or one can perhaps use a non-biologic material, a silicone type of material, or some people would even use radiated cadaver grafting. Tell me your thoughts on what you prefer to use and why.
Yeah, great question. I love that question just because my approach has changed in the past 5 years. Doing a lot of revisions, I have to deal with a lot of rib, and that's always a hard conversation to have with a patient. They already went through a surgery. Now they're traumatized because it didn't end up the way they expected it. Now you tell them not only are you going to have another rhinoplasty, but now I have to take part of your rib. Kind of scary conversation for patients. To me and you, it's just another day at work, but to the patient, it's really a huge barrier. I don't want to differentiate, but especially for women, to me that's like not something they look forward to. So that's why keeping up with the latest science is really key. And I saw a lot of literature about cadaver rib, the predictability and success rate. And coming from oral maxillofacial background, where I'm very familiar with allogeneic grafting and bone grafting in particular, and head and neck reconstruction, it was nothing new to me. And so once I started using that and seeing just as good of results and predictability with allografts, which is cadaver rib, I haven't done a rib harvest in, I would say, 4 years, 5 years. And so it significantly reduces the morbidity, which means basically chance of possible complications from harvesting the rib. And so as far as additive, I love now my preferred method is cadaver rib. I do not like any Celastic or any like silicone. That's a lot. They use that in East Asia a lot for Asian rhinoplasties. I see a lot of problems with that. So, and when you have problems there, it could, that they're not easy to fix. And I rather reconstruct the nose, which is not only more predictable, but to me is honestly more fun. I see a lot of patients that come from Asia, and interestingly, they tell me their surgery took literally 15 minutes in the chair. They just made a little incision and just put that L-strut silicone in there, and they were done. And then you just can't possibly address the entire nasal anatomy just sticking a piece of silicone there. You see the edges, it protrudes, and you see blanching on the skin. It just doesn't look natural. Actually, one of my surgical assistants has one of those, and that she wants me to revise. So there is ultimately what I would tell my patients is, look, there's no right or wrong way. Is whatever works in the surgeon's hands, that's the way to go. And there's different ways to skin the cat. For me personally, I like to know where I'm starting and where I'm going with things. And so that's what my context of saying all of this is.
Okay. Earlier you mentioned non-surgical rhinoplasty, which we talk about as can be filler or even fat or other types of material. Some of the marketing hype is the terms are liquid rhinoplasty. Tell me the good and the bad of non-surgical rhinoplasty. When would you use it? When would you not use it?
Well, for your audience that have consumed my content on social media, they know how I feel about fillers in general. Especially fillers used for non-surgical rhinoplasty. Have I done them? Absolutely. Would I consider them? Yes, but in very rare indications, not as a replacement to rhinoplasty surgery. Let's go through some examples. Let's say a patient comes and they have a little irregular hump where, for example, the radix, which is the part of the bone that's in between your eyes, that's really deep, and that gives the appearance just below that area of a hump, okay? If I can just do a little bit filler, augment that, and we're done, patient is happy, so be it. But the problem with liquid rhinoplasty or with fillers into the nose, people are starting to get a little too fancy, especially people start injecting fillers that mainly don't have yet obtained the ability to diagnose the problem of the nose. So when you don't diagnose the problem, you get confused as to where to inject. For example, you try to give a patient more projection of the tip, and you say, well, that's easy, I'll just inject some filler to the tip. What you don't realize, if a patient already has a bulbous tip, and you think you can augment the tip by adding filler, now you made the tip rounder and larger than it already appeared, especially if that patient had like a narrow ridge, for example. So that's the part where patients, I caution them to just, I guess, choose what sounds to be or too good to be true, and kind of get tempted to choose that route because it's cheaper, faster, no surgery. I know it sounds very sexy, but you just got to be careful. So in my practice, again, I do minor contour irregularities, or I had a patient last year, after rhinoplasty, she had just above the supratip, which is between the tip and the dorsum of the nose. It was a little bit too scooped out for her, for her taste, and I just added a little filler, and she loved it, and we were done with it. And I gave her the option. I said, look, I could do a quick revision. I just put a little bit cartilage graft, just a little bit crushed cartilage graft, and you'd be done. I'm not sure why that area got a little scooped out. And we looked even at the immediate after picture. It didn't look like that. And so I added filler. So do I do them? Yes. However, very select cases.
I think that there's a place for them, for everybody, refinements, small little things. But I think that, as you touched upon, if you can't do a surgical rhinoplasty, you probably shouldn't be doing a non-surgical rhinoplasty.
That's a great point. I think you just hit the nail on the head. I think non-surgical rhinoplasty or fillers, in the nose, they should only be done by rhinoplasty surgeons, period, because it starts with the diagnosis. And like we say in surgery, if you do a surgery or any treatment, it's a medical treatment. If injecting filler is not a joke. A patient just told me she was on a Norwegian cruise and she went to a med spa and they tried to sell her a filler injection on a cruise. So I think it's getting a little out of hand. So to me, it's a medical procedure. You're injecting a foreign material into someone, and there could, as well as anyone knows, the complications that can occur from potential intravascular, meaning injecting filler into a blood vessel, potentially causing tissue necrosis or even blindness. We should never, we say in medicine all the time, you should never do something that you can't treat or handle a complication, period. And therefore, to me, a filler into the nose should be only performed by a rhinoplasty surgeon, period.
And there's very, very little in our world that doesn't have the potential for complication. So we've got to know how to handle it. So we talked earlier that with a rhinoplasty, we want it to be a harmonious balance with the patient's face. But sometimes you just can't get a balanced face with a simple rhinoplasty.
Tell me about it.
What do you do in those cases?
Those are tough, hopefully you can predict that before you do just a rhinoplasty. Like, you don't want to be in a situation you thought you nailed the nose and you look at the picture, you're like, man, this just doesn't look right. And you don't know, is it because you didn't do a good job on the nose, or is it something that you missed? For example, the chin. Or maybe the forehead, or maybe the cheekbones, or maybe the lower face is too round. So there's so many different things that you have to, and that goes back, Peter, that goes back to experience, to predict things before they happen, before you do something. And that purely is experience. I can't tell, I can't put it any other way. So anytime I do a rhinoplasty, I look at the facial profile. Now, I come from, historically, I'm trained oral maxillofacial surgeon. Our primary surgery, reconstructive surgery, we perform is orthognathic surgery. So I'm automatically in tuned with skeletal facial relationships. And that's something that my eye just subconsciously picks up. I don't have to make measurements. I don't have to make a cephalometric analysis, which is basically analyzing all the angles of the facial skeleton, of the facial soft tissues, coming up with a perfect profile or facial proportion. So automatically when I look at the nose, I look at the lower jaw, I look at the maxilla, I look at is the relationship between the upper and lower jaw, is it an underbite, is it an overbite, does patient have midface hypoplasia, which is deficiency of the midface? Do I need to augment that? So at least I have that conversation with the patient, and I explain to them what I mean by that, because sometimes they don't understand it if you tell them. So that's why pictures are great. I show them pictures of other cases that I've done. Here's a rhinoplasty I did on a patient without the chin that needed a chin. Here's a rhinoplasty of a patient that needed a chin, and she agreed with me doing the chin, and look at the difference. So I think a lot of times we underutilize the power of images. So, once you're like us, many years into the second or third decade of your career, you have accumulated enough pictures, enough examples for every case scenario. And I think that's why I always teach my residents and fellows, I'm like, look, take pictures from day one, because you never know when you're going to need them, because there is a patient that will walk through your door and it's exactly that example that you would need. And instead of spending half hour explaining what you mean, you can just show them a picture, and in 3 seconds they know exactly. And so that to me is key. It's hard to explain a patient, well, you have a weak chin. If I do your nose, it's still going to look big because your weak chin will not be balanced. And patients don't understand it, Peter. They just don't understand it. They think you're just talking them into an additional procedure. Until you build that level of trust, they always are skeptic, which I don't blame them. I absolutely understand it. That's what I would do, to be honest. I'm skeptic myself. And so showing them pictures is really key to make them understand what you actually mean. So I
think we as surgeons need to utilize what tools we have. And as time goes on and technology goes on, we have more and more tools. But you're right. I think the key is balance. And if we could get something across to the patient that we're not trying to upsell, we're trying to show you that fixing one thing may exacerbate or may draw attention to something else. So I think with showing visuals and showing people how it can create a better balance if you're not just focused on one thing but looking at the entire structure of the face, that's probably the key takeaway for many of our patients to understand that it's all about balance.
And just to that point, several years ago I had a patient. She came. She was convinced her nose is too big. I looked at the nose. It looked perfect. And I told her, I said, I was writing a chapter at that time on rhinoplasty. I said, look, your nose looks so perfect. I would ask you for permission to take a picture and put it as an ideal nose, because I have never seen a nose that perfect, because, it's just, and I don't want to just have someone draw a perfect nose. It's better if I can have a picture of a perfect nose. She thought I'm like trying to, I don't know, convince her or whatever, or talk her out of it. And I said, your problem is your chin is too small. And she's like, what do you mean? I've never heard that. No one ever told me that. I'm like, look. And once I showed her, so guess what? I ended up doing actually a genioplasty, an advancement genioplasty. And she looks amazing, and she totally loved it. And I didn't even touch her nose. To that point that it's about facial balancing. And sometimes it's another part of your face.
Excellent advice. Dr. Daria Hamrah, I'm so happy that you are with us today. Tell the audience where they can find you in your practice.
Well, they can find me on the internet. Just Google my name, Daria Hamrah, and everything will come up. My social media outlet on Instagram, @Dr. Hamrah, on TikTok, Real Face Doc, and Facebook, all of the outlets. And you can just Google my name, and it will come up just like your name comes up. And
you have a podcast. Tell us about the podcast.
Yes, as a matter of fact, you'll be my guest pretty soon.
I hope so.
So for your audience, if they want to listen to an up close and personal interview with you, just on same outlets you're on. iTunes, Spotify, Google, Audible. It's the Daria Hamrah podcast. I made it very simple. And it's about inspiring people through storytelling about anything from business, from marketing to entrepreneurship to medicine, to just hearing someone's story that was crazy. That's what my podcast is about.
And I look forward to being on it and listening to all of your podcasts and continuing a collegial relationship and a good friendship. Daria, thank you so much for being on this podcast. This concludes another episode of Beauty and the BS. Thanks for joining us. We'll see you next time.
Thank you.